So good question. So in a larger philosophical level, generally speaking, in cancer therapeutics, and this is true of prostate cancer as it is of other therapies or other diseases, treatments that are effective in the very latest phases of the disease tend to be more effective and better tolerated when they're moved up earlier in the disease. And that's generally because there's fewer resistance mechanisms at play earlier in the disease. There's less of a tumor volume, and also the tumor burden is, it has a better proportion to the patient's general health, better organ functionality, and they're generally in better shape. So that's an abstract reason as to why to do it. And then more specifically for PSMA-directed therapy, it was approved very late in prostate cancer history. So in very advanced patients after they had progressed through ADT and ARPI and after they had progressed after chemotherapy. So there's a big effort to see if we can't amplify on the efficacy and tolerability seen in those really advanced patients to earlier phases of the disease. In terms of data specifically to support this shift, well, these trials are ongoing. So we only have the reference point that moving drugs earlier in the disease has been beneficial to patients in virtually every other therapy for prostate cancer. But for a drug like lutetium-177 PSA-617 or Pluvicto, we don't have that data yet. The data is being collected through a trial called PSMAddition. Well, I think that right now, the main effort is to see whether lutetium can be added to the current standard of care for castration-sensitive metastatic prostate cancer. So PSMAddition has a design of ADT and an ARPI with or without lutetium in an effort to define whether 3 drugs is better than 2 drugs for these patients. There has also been an earlier phase 2 study called UpFrontPSMA, which combined lutetium with docetaxel in these patients. So that was 2 cycles of lutetium and then 6 doses of docetaxel versus docetaxel alone. But I think that what's also worth considering in the future is whether or not lutetium not only can be added to existing standards, but can substitute for existing standards of care. And in that respect, it would be nice to have a therapy that could replace ADT and an ARPI or serve as in addition to just ADT in lieu of an ARPI. So there are many permutations that need to be explored, both those that augment current existing standards and those that supplant current existing standards. Well, these challenges relate to the timeframes that the patient generally has in terms of their disease course. So right now, for example, in lutetium's current approved space, patients have a very limited lifespan because they have such advanced disease and they've progressed through most active therapies. So we're really talking about just a little bit over a year in terms of the quality of life and long-term toxicity window that we're most concerned about. But as you move earlier in the disease course, the timeframes get much longer. So if you're looking, for example, a castration sensitive metastatic disease, then really you're talking about timeframes that are 4 to 6 years plus. And in that circumstance, then there's really long-term toxicity that may emerge that you otherwise wouldn't see in very advanced disease. Nephrotoxicity and marrow toxicity. There are also longer time frames. So patients may well relapse down the line. And remember that in the current FDA-approved space, they're looking at really overall survival that's pretty limited. But in this earlier space, there are many treatments that these patients could still get in order to prolong their lives. And you're concerned then that emerging long-term toxicity from lutetium might interfere with receiving those additional therapies at relapse that could also prolong life. From a quality of life perspective, also, patients with castration-sensitive disease tend to feel really pretty well, and they do so for many years. So, treatment-related toxicity is that much more of a serious consideration because we could be talking about long-term side effects that the patient needs to bear for many, many years. Having said that, I think it's important to recognize that radioligand therapy is a very well-tolerated treatment and with a very favorable side effect profile, especially with the beta emitters. And so the likelihood of lutetium and other radioligand therapies, whether PSMA directed or otherwise directed, has a good chance of meeting these challenges in terms of long-term tox and long-term quality of life. But having said that, as we transition to the alphas, which can have significant xerostomia, for example, risk of second malignancies down the line, although very, very small, we need to, or nephrotoxicity and marotoxicity, we need to explore the issue of toxicity and side effects and quality of life, and really define what the tox profile is of these alphas if we are going to move them ever earlier in the natural history of the disease. There's a lot of additional evidence that we need. So right now, moving early in prostate cancer for the betas is an ongoing process. There are a number of clinical trials that are open, and if they haven't already accrued and we're waiting for events, then they're accruing now. I mentioned PSMAddition. There's also in the even earlier space in which patients have really oligometastatic disease. There are a number of clinical trials looking at radiation and lutetium, external beam radiation and lutetium combination studies in the absence of ADT. There are studies looking in the neoadjuvant and adjuvant space as well for primary therapy. So we have more data to collect than data that we have to justify the use ever earlier, but the trials are ongoing. And that's also a wide open world in terms of the alpha emitters. And earlier therapy is probably the most appropriate place to put an alpha emitter if you want to actually cure patients. But again, no data. So we need a lot of additional data before we even begin to consider moving these drugs earlier and consider them as a standard of care. These trials need to be performed, they need to be completed and analyzed. And before we discuss a standard application of these drugs in the earlier context, we need the data to results.